am Professor Patrick.
Professor?
Dr. Professor Patrick.
Now we can move on into the pulmonology section. So some of the learning objectives here, we want to categorize obstructive and restrictive lung diseases and their treatments. We want to determine the infectious or immune cause of hemoptysis and cough. And we want to decide the management of lung nodules, including lung cancers and paraneoplastic syndromes. We want to analyze pleural fluid composition and determine etiologies. We want to classify acute causes of shortness of breath and stratify their risks. And we want to identify common chest pathologies on x-rays. We'll have sort of a quick image answers at the end. So our obstructive versus restrictive lung disease is the most common thing that we can do to sort of stratify somebody with shortness of breath who comes in. So the most common obstructive lung diseases are asthma and COPD, versus restrictive lung diseases are like interstitial disease, structural or neurologic problems. So what you want to do is PFTs to see sort of what the different lung volumes are. So usually everything's the same. The big one to look at is the FEV1 to FVC ratio. So if it is less than 80% predicted, that is an obstructive lung disease. If it is normal to increased, then that's going to be a restrictive lung disease. So if you think about the ratio this way, the amount that they can blow out in 1 second versus their total lung volume, if you're obstructive, if you're asthma or COPD, you've got air trapping. You can't get out all the air very quickly, so they have prolonged expirations, and that's why it's lower. Somebody with restrictive lung disease, think about somebody sitting on top of your chest. You can blow out all the air very quickly, but you don't have a lot of air to blow out. So the ratio goes up, even though both of the FEV1 and FVCs are lower. So the most common illness script that we would have here for COPD is the blue bloater and the pink puffer. So we've got a 65-year-old couple that comes to the physician for chronic coughs with clear sputum. The pair have been dealing with a pesky cold that lasts for 3 months. They're detailed similar colds that happened the year prior as well. So they have a 50-pack year smoking history with 2 to 3 packs per day. On exam, the husband is overweight and cyanotic with an increased chest diameter. The wife appears cachectic and visible distress with prolonged respirations through pursed lips. So the criteria for diagnosis of COPD, you want a productive cough for greater than 3 months for greater than 2 consecutive years. An exacerbation is going to be a change in their sputum, an increase in dyspnea or O2 requirements. So the next best step for these two that come in is PFTs with a diffusion of CO2 in response to bronchodilators. So this is how we can gold stage them. So consider alpha-1 antitrypsin levels if there's a family history, liver cirrhosis, or young diagnosis. And then if they're in exacerbation, we also want to order ABGs. So the treatment algorithm for this, first line, anticholinergics. This is going to be different than your asthma treatment. Second line is beta agonist. Third line is inhaled corticosteroids. And then you can consider theophylline. So in terms of mortality, quitting smoking can decrease the rate of FEV1 decline, and then continuous oxygen therapy greater than 18 hours a day if they have a certain O2 requirement, PaO2 of less than 55 or SpO2 of greater than 88% or less than 88%. So either of these will decrease mortality, but none of the other therapies mentioned above will decrease it. It will only increase symptoms and decrease hospitalizations. So if someone comes in with an exacerbation, say both of these men and women come in, increasing cough, change in their sputum, so this is going to be an exacerbation. We want to treat their O2 to within 90 to 93. So we worsen the VQ mismatch and the Haldane effect if you get it above 93 to 95%. So you want to keep their O2 right about 90 to 93. You want to start duonebs or albuterol ipratropium nebulized. You can try PO or IV corticosteroids, and then you can try a fluoroquinolone or a macrolide antibiotic. Usually the macrolide antibiotic is thought to decrease inflammation within the lungs. So that's used even if you don't think this is a bacterial cause, maybe a URI causing this. Important vaccinations that you need all your COPDers to get is a pneumococcus with a 5-year booster and yearly influenza because they're at increased mortality. So now with asthma, usually a younger patient, so we've got a 23-year-old here, coming for shortness of breath and chest tightness. She's also noticed a dry cough that's worse at night, which is a common sign for asthma. She's got a history of childhood asthma, eczema, and food allergies, or atopic syndromes here. And on exam, there's diffuse wheezing in all lung fields. Laboratory studies reveal eosinophilia. So your next best step is going to be spirometry before and after bronchodilators, or you can try a methacholine challenge, which is a cholinergic medication that can induce a bronchospasm. So in exacerbation, you want to check a chest x-ray for pneumonia or pneumothorax, and you want to monitor ABGs for the CO2 normalization. If it's normalizing, that's a sign of impending respiratory failure. Treatment here is going to be based on severity of symptoms. So if it's mild to severe, and if it's intermittent to persistent. So your step-up therapy is going to be starting with a short-acting bronchodilator. The next step up is going to be inhaled corticosteroids. Next step would be a long-acting bronchodilator, and you can also try leukotrienes. And then rarely you can do cromolyn, omalizumab, or theophylline. So during exacerbations with somebody with asthma, you would want to do a nebulized short-acting bronchodilator, a corticosteroids, magnesium, and you want to watch closely for the need to intubate these patients. Moving into cystic fibrosis and Cartagener's syndrome. So these are going to be usually younger men or women from usually a European country presenting to the physician following immigration. He has had a recurrent pulmonary infection since childhood with production of purulent and bloody sputum. He's also had stomach pains and trouble gaining weight. Vital signs show a temperature of 37.9, BP of 118/82, pulse of 84, and respirations of 20. On exam, there are rhonchi and wheezes, and there are clubbing seen on the hands. So your next best step here when you're thinking cystic fibrosis is a sweat chloride test. The definitive test is going to be a genetic autosomal recessive trait, and this is involving the sodium chloride transporter. The most common genetic trait is going to be the delta F508, and it's a congenital absence of the vas deferens can be seen as well. So for treatment, you can do chest physiotherapy, DNase, inhaled hypertonic saline, pancreatic enzyme replacement therapy, immunizations, and lung transplant. So aggressive therapy is usually to remove the mucus from the lungs. So there's not enough water being excreted following the salt. And then the mucus builds up, and you can also get buildup of then bacteria. So antibiotics are usually targeted against Pseudomonas, MRSA, and other multi-drug resistant organisms. They'll commonly get infections beginning in early childhood, which require antibiotics, and then slowly over time you develop antibiotic resistant organisms colonizing their pulmonary tract. You can compare this with Cartagener's syndrome or primary ciliary dyskinesia. These people also have recurrent pulmonary infections and sterility in males. Interestingly, in 50% of them, you can have situs inversus, where the heart is on the wrong side of the chest. And this is from the ciliary not being able to push the heart in the right direction. And they get these recurrent infections because they are not able to push the mucus from the lungs and expel it out of their mouth. And all of these are kind of similar to bronchiectasis. So bronchiectasis is usually, say, a 43-year-old patient with recurrent URIs and new onset hemoptysis. So there's foul-smelling sputum, and vital signs usually show an elevated temperature and elevated respirations. And there can be faint rhonchi and wheezes on exam and poor air movement. So this is due to those enlarging bronchial tubes from necrolizing infections along it. The next best step is going to be PFTs, which will show a obstructive pattern, so an FVC and FV1 with increased ratio. And imaging, like a high-resolution CT, is easier to see than a chest x-ray. So some of the causes are cystic fibrosis, Cartagener's, and recurrent infections, say due to a humoral insufficiency. And to treat this, you want to give antibiotics, hydration, and chest physiotherapy to decrease further destruction by other infections. Moving into restrictive lung diseases. So these can have a bunch of interesting causes to look out for. So we have a 59-year-old man who presents for dyspnea. His dyspnea began while exercising and slowly progressed to persistent and non-productive cough. He has a history of non-Hodgkin's lymphoma treated with radiation and chemotherapy 5 years ago. Vital signs are appropriate, and on exam rales are heard at the lung bases, and digital clubbing is seen. So some of the causes of restrictive lung disease can be divided into interstitial causes, like environmental exposures, granulomas, like sarcoidosis, histiocytosis, Wegener's, Churg-Strauss, some drug-induced pulmonary fibrosis caused by amiodarone, nitrofurantoin, bisulfan, bleomycin, phenytoin, and then radiation, connective tissue diseases, and some other idiopathic causes. There's also structural causes of restrictive lung diseases. Think kyphosis, where the spine is bent so that they can't fill up the lungs. Increased obesity can't fill up the lungs. And diaphragmatic hernias, rib fractures, and pleural thickening. And then there's also neuromuscular causes of restrictive lung diseases. So if you have a diaphragmatic paralysis from the phrenic nerve, if you've got myasthenia gravis, where you're unable to use the diaphragm to effectively fill the lungs, ALS, MS, and muscular dystrophy are all causes. So your next best step for all of these is going to be a chest x-ray. And then a high-resolution CT is helpful for a lot of the interstitial causes. And in some cases, you're going to need a tissue biopsy or a bronchoalveolar lavage or other serologic and renal testing. So the treatment is to address interventions to the underlying cause. We'll go over some of these now. So some of the pneumoconiosis that you can get, we'll do common illness scripts for these, what causes the infection, and then what to watch out for. So there's a 42-year-old sandblaster glassmaker with shortness of breath, and on chest x-ray there is 1 centimeter nodules in the upper lobe, described as eggshell calcifications. So this is silicosis, increasing risk with sandblasters, anyone with glass. And you have an increased risk of TB here. It prevents the macrophage's ability to kill the microbacterium. So you want to screen them with PPDs and treat them aggressively. Remove the offending agent, so no more sandblasting. Next up, we've got a 51-year-old alfalfa farmer who presents with cyclic fevers, headaches, and cough while working. Chest x-ray shows a patchy lower lobe infiltrate, and biopsies show thermophilic actinomyces. So this is a hypersensitivity pneumonitis, or a farmer's lung. It's a type 3 sensitivity, creating IgE and IgGs against this bacterium, and the treatment is going to be to remove yourself from the farm. Next up, we've got a 36-year-old Pennsylvania coal miner who developed shortness of breath and joint pain, worse in the morning. Chest x-ray shows hazy opacities in the upper lobes with multiple well-defined nodules. And then hand x-rays shows marginal erosions with osteopenia of the PIP and MCP joints. So this is coal miner's lung. Anybody who's working underground in the coal mines can get this. And then specifically Kaplan syndrome is an acute form where they're prone to rheumatic arthritis as well. So next up, we've got a 36-year-old who presents with shortness of breath shortly after moving into a new home built on a former computer and aerospace manufacturing plant. Chest x-ray shows upper lobe calcifications, and a beryllium lymphocytic proliferation test is positive. So this is berylliosis. It can be caused by runoff from computer and aerospace manufacturing, so a lot of microchip plants. And you're going to look for upper lobe granulomas similar to silicosis or TB, and it can be treated with steroids. So lastly, we've got a 68-year-old former Navy shipbuilder and building contractor who presents with progressive shortness of breath and weight loss. He's got an 80-pack year smoking history. Chest x-ray shows pleural plaques and reticulonodule processes in the lower lobes. So this is asbestosis or mesothelioma, and smoking increases your risk of bronchogenic carcinoma and mesothelioma by more than 32 times. So if anyone has exposure to asbestos, it's recommended to stop smoking immediately. One thing to help remember these, so the first 4 were all in the upper lobes, and these are usually things from the ground that cause infections in the upper lobe, and then asbestosis is usually found in insulation, like in roofing and things, and that causes infections in mesothelioma in the lower lobes. So things that come from the ground in the upper lobes, things that come from the roof in the lower lobes. Now we're moving on to sarcoidosis and granulomatous diseases. So a classic presentation of sarcoidosis is a 27-year-old African-American woman presenting for dry cough and dyspnea on exertion for 3 months. Review a system. She is pan positive for symptoms ranging from malaise, eye problems, arrhythmias, skin rashes, and joint pains. So sarcoidosis is the great mimicker, just like lupus and SLE. So next best step here is a chest x-ray. We want to look for bilateral hilar adenopathy. Other workups, we can look for increased ACE, hypercalcemia, and an increased CD8 to CD4 ratio. Definitive diagnosis is made by biopsy, showing non-caseating granulomas. So some of the associated findings that we can see here are erythema nodosum, heart block, Bell's palsy, arthritis, or like a Lofgren syndrome, anterior uveitis, which needs an urgent ophthalmologic referral. And then treatment is going to be self-resolving. Otherwise, you need steroids and methotrexate if there's no response. Some other granulomatous diseases that you can look for is histiocytosis X. It's usually going to be a cigarette smoker with shortness of breath and lytic bone lesions and a pneumothorax. On chest CT, you can see honeycombing. Wegener's granulomatosis, or granulomatosis with polyangiitis, is recurrent sinus infections, hemoptysis, and elevated kidney functions. It's associated with an elevated C-ANCA, and you treat it with steroids and cyclophosphamide. And then lastly, Churg-Strauss is another vasculitis with asthma and rash. This is P-ANCA positive and eosinophilic, and we treat this with steroids. So some miscellaneous interstitial lung diseases. So we've got a 41-year-old woman who presents with progressive shortness of breath and non-productive cough. She's got no history of connective tissue disease, autoimmune disease, or environmental and occupational exposures. Lung imaging shows ground glass and honeycombing pattern. This is common for idiopathic pulmonary fibrosis. You need a definitive diagnosis with biopsy, and you treat with oxygen and eventual lung transplantation. So other interstitial lung diseases are pulmonary alveolar proteinosis. So this is dyspnea, cough, and rales, and you also diagnose this with biopsy. You can treat it with granulocyte colony stimulating factor, not steroids. And we've got cryptogenic organizing pneumoconiosis, or COP, and this is usually cough, fever, and dyspnea with a ground glass. It's thought to be a virus or autoimmune, and you can treat this with steroids. And then lastly is radiation pneumonitis, where you get fever, cough, dyspnea, and chest pain. Usually the acute phase is 1 to 6 months after having radiation exposure. The chronic phase is 1 to 2 years or more. And a CT scan can show diffuse interstitial or infiltrates, and you treat with steroids. So now moving on to hemoptysis. Two of the causes of hemoptysis, TB and Goodpasture's disease. So we'll compare those now. We've got a 58-year-old immigrant from Southeast Asia presenting with fever, fatigue, weight loss, and a cough productive of flecks of blood. She was previously well until 6 weeks ago when her family went to Laos. Her vital signs are temperature of 38.1, normal BP, elevated pulse, and respirations of 22. Crackles and rhonchi are auscultated in the upper lobes. The next best step is isolation of the patient in a negative pressure room. We don't want to spread TB infection anywhere else, and initiate airborne precautions and call the CDC. A chest x-ray can show upper lobe infiltrates, or a GON complex is what it's called, and you want to rule out TB with 3 negative sputum cultures. So if this patient were positive for TB, we want to treat with RIPE therapy for 2 months, followed by just rifampin and isoniazid for 4 extra months. And we treat all close contacts with rifampin. If someone was positive for a latent TB, so say they had a positive PPD and a negative x-ray, we want to treat with isoniazid for 6 months or rifampin for 9 months. When treating with isoniazid, be careful for B6 deficiency, which can cause a glove and stocking neuropathy. You can screen with a PPD, which is looking for a type 4 hypersensitivity reaction to the tuberculone bacterium, or quantiferon gold exam, which is a one-step process. So if the PPD is greater than 15 millimeters, it's going to be positive in all people. If it's greater than 10 millimeters in healthcare workers, immigrants, those with IV drug use, or children, that's going to be a positive result. And anything greater than 5 millimeters in someone with HIV or immunosuppressed should be contacted and treated for TB. So if we compare this with Goodpasture's disease, this is oftentimes a young male with hemoptysis and hematuria. So think 44, 45-year-old male with hemoptysis, Goodpasture's disease. So we can diagnose with a tissue biopsy and with IgG, antiglomerular basement membrane antibodies. So this is a type 2 hypersensitivity reaction to the basement membrane in the lungs and the kidney. And it's also positive for a P-ANCA at times. So we can treat this with plasmapheresis, cyclophosphamide, and steroids. So moving into the most common pulmonary infection that we see, community-acquired pneumonia, so CAP. So we have a 67-year-old diabetic man presents with fever, chills, cough, and shortness of breath for 1 day. Vital signs show normotensive with an elevated pulse and respiration rate, and he's got a temperature of 38.9. On exam, the patient has increased tactile fremitus and bronchial breath sounds in the left chest. Labs show leukocytosis and a mild AKI. So the next best step here is a chest x-ray to differentiate pneumonia and bronchitis, and to do blood cultures, sputum cultures, and gram stain to help guide the treatment. So the treatment, one of the algorithms you can use is CURB-65 to guide where your location is going to be. So if there is confusion, uremia, a respiratory rate greater than 30, or blood pressure less than 90/60, depending on how many points, you're going to want to treat outpatient, observation, or inpatient. Antibiotics are usually empiric, so we give macrolides or doxycycline for an atypical or an outpatient treatment. We can give cephalosporins or respiratory fluoroquinolones in a typical treatment of a pneumonia, so a lobar pneumonia, and third-generation cephalosporins and macrolides are used inpatient with a more severe pneumonia. Some of these atypical pneumonias are walking pneumonias. So we've got a 25-year-old medical student presenting with fever, headache, sore throat, and a dry cough. On exam, he's afebrile with mild wheezing throughout. So we can call this a walking pneumonia. It's more of a mild type. We can diagnose it on chest x-ray with an interstitial infiltrate and treat with macrolides or doxycycline. Some of the most common causes are mycoplasma, chlamydia, coxiella, or legionella. Speaking of legionella, the common presenting finding for that is a 68-year-old with acute cough, fever, diarrhea, and confusion, which are unique. While on a cruise, labs show leukocytosis and hyponatremia. So chest x-ray shows a lobar pneumonia. So you can diagnose Legionella pneumonia with a urinary antigen, and you want to treat this with a macrolide or a fluoroquinolone. So some of the other things to look for: a 54-year-old man with a history of kidney transplants presents with recurrent fever and cough. Sputum shows a dimorphic yeast. So now getting into the dimorphic yeast causes of pneumonia. So you would diagnose it by size or urine and blood antigens. So histoplasmosis, geography-wise, it's in the Mississippi River Valley, or anybody who goes on spelunking trips. Next up, blastomycosis is in the Ohio River Valley, so slightly north. And bone and skin infections are common with this one as well, and you can diagnose it with a urinary antigen. Next up, we've got coccidiomycosis, which is in the southwest, or San Joaquin River Valley fever, and it can happen after dust storms or Burning Man. And then paracoccidiomycosis is in South America. This is the largest. So with all of these, we can treat with itraconazole or amphotericin B if there's disseminated infection. And once again, look for these causes based on geography, if they mention it, or if they have a history of immunosuppression. So now, what to do if there is concern for lung cancer or lung nodules? So we have a 72-year-old who presents for fever, cough, and malaise for 1 week. He has a 50-pack year smoking history. Vital signs are temperature 38.1, BP 129/88, pulse of 97, and respirations of 20. On exam, rhonchi are heard in the left lower lobe, as well as an increased tactile fremitus. Chest x-ray shows a lobar pattern of consolidation and a 3-centimeter coin lesion or nodule. So the next best step here, dealing with the coin lesion, would be a biopsy. So based on the risk factors, age, smoking, size greater than 2 centimeter, increasing, or if it's calcified, we're going to want to look at low risk nodules with serial CT scans, intermediate risk nodules 1 centimeter or larger with a PET scan, and then high risk nodules we want a biopsy. So if there's an option for finding a prior imaging study to compare a nodule to, that's going to be your best step. Treatment depends on the TMN staging and the type of cancer. So you can divide up cancers into non-small cell lung cancers and small cell lung cancers. For your non-small cell cancers, surgical and radiation options are available if the TMN staging is low. And small cell lung cancer, the only option is chemoradiation and immunotherapy. So screening low-dose CT scans you can do in 55 and older with a 30-pack year history, and they still smoke or they quit within 15 years. This is important to possibly diagnose it at an earlier TMN stage. So now, some of the lung cancer effects. So these are all mass effects, not paraneoplastics. So we have a 66-year-old with a large smoking history presents after being lost to follow up with hemoptysis, weight loss, and a suspicious lung nodule. So now some of these symptoms are facial fullness, edema, dilated jugular venous veins, and head pressure when leaning forward. So this is superior vena cava syndrome, which is associated more with a squamous cell carcinoma because these like to form in the upper lobe centrally, and they can put pressure on the SVC, causing SVC syndrome. So what if he had shortness of breath and an elevated hemidiaphragm on chest x-ray? So this is phrenic nerve palsy. Another one of the central squamous cells or small cells can actually eat away at the phrenic nerve and cause an elevation of the hemidiaphragm. So hoarseness and loss of voice is a recurrent laryngeal nerve palsy. Pinpoint pupils and a drooping eyelid with no sweating on the face is Horner syndrome, and that's a cervical sympathetic chain invasion. So you get the classic anhidrosis, ptosis, and meiosis. And then progressive pain and weakness radiating down one arm. This is a Pancoast or superior sulcus tumor. So this starts to invade C8, T1, and T2 nerve roots, or even the brachial plexus. So now, when we look at our non-small cells versus small cells, so our non-small cells are squamous cell, which is related to smoking. It's more of a central location, and it can cause hypercalcemia due to parathyroid-like peptide. So that's its paraneoplastic syndrome. You have adenocarcinoma, which is the most common cause in non-smokers, and it's peripheral, includes bronchoalveolar subtype that grows along the wall, so it's a bronchoalveolar in situ cancer. And then you have large cell cancer, which is related to smoking. It's peripheral, and it's very anaplastic. Compare that to your small cell lung cancer, which is about a quarter of all lung cancers. It can be called oat cell cancer. It's related to smoking. It's also centrally located, and it causes multiple types of paraneoplastic syndrome. It can cause Cushing syndrome due to release of ACTH. It can cause SIADH, Lambert-Eaton syndrome, and anticerebellar syndrome. So we'll go over those paraneoplastic syndromes now. So once again, we've got a 60-year-old construction worker who presents to his PCP with a cough and bloody sputum. He smoked 2 packs per day since he started working at 15 years old. On review of systems, he also mentions that he has been unable to perform his work duties due to fatigue and weakness that improves throughout the day. His pupils are equal reactive and respond to light. His extraocular movements are intact and upward gaze is intact. And then he has 4 out of 5 strength that improves with repeat testing. So this is Lambert-Eaton syndrome. When you compare it with myasthenia gravis, this is going to improve with use rather than decrease with use. Usually the eye muscles are spared and the upward gaze is intact. So this is an anti-postsynaptic calcium channel antibodies due to a small cell lung cancer. So he also mentions he's been drinking a lot of water, but he hasn't had to urinate very much. Laboratory studies show a serum sodium of 120, which is extremely low. So this is syndrome of inappropriate ADH. This is ectopic ADH production by a small cell lung cancer that causes hyponatremic normal volemic state. And you want to check urinary sodium and urinary serum or osmoles. So we'll also go over sodium and electrolytes at a later time. So he mentions he's easily gained weight and his midsection and upper back and his face looks more rounded and his skin bruises very easily. So this is more of a Cushing syndrome picture with ectopic ACTH produced by a small cell lung cancer. So someone who's been urinating very often, confused, constipated, he has back and leg pain. His serum calcium is 12.9. This is hypercalcemia of malignancy. This is due to parathyroid-like hormone production or bone mets in a squamous cell cancer. So you want to give IV fluids and then loop diuretics. And he also says that he has a hard time keeping his balance and he's making strange movements with his arms and legs. Friends have said that he says odd things and has rapid move swings. So this is anti-WHO encephalitis. This is an anti-neuronal antibodies associated with small cell lung carcinoma and neuroblastomas. So moving into acute respiratory distress syndrome. So we've got a 36-year-old male who was brought to the ED after a DUI and motor vehicle accident. He was being treated for blunt abdominal trauma and acute pancreatitis when his vital signs started dropping. His blood pressure is 110/67, pulse of 109, and respirations are 28 per minute with a saturation of 87%, and it's not improving on 100% oxygen supplementation. So your next best step here is a chest x-ray. And somebody with ARDS is going to have diffuse bilateral infiltrates, or a whiteout of their lung. On arterial blood gas, you can look at severity based on the PaO2 over FiO2 ratios. Somebody 200 to 300 is usually mild, 100 to 200 is moderate, and greater than or less than 100 is severe ARDS. So the next best step in management is to increase the PEEP, the positive end expiratory pressure. The goal is for oxygenation around 90%, and fluid overload should be avoided. So your pulmonary catheters are often debated here. So causes are sepsis, aspiration, trauma, pancreatitis, drug intoxications, transfusions, and drowning. Moving into pleural effusions, we've got a 65-year-old woman presenting to the ED with shortness of breath and a feeling of drowning. She has a history of breast cancer, nephrotic syndrome, and cirrhosis. She states that she ran out of medication 2 days ago and came back from a Chinese buffet restaurant. Vital signs are temperature of 37, BP of 156/98, pulse of 76, respirations of 24. On exam, rales are heard prominently in the lower lobes with dullness to percussion and decreased breath sounds. Next best step in diagnosis is a chest x-ray. You can get PA and lateral films, and your first sign is going to be blunting of the costophrenic angles with about 250 milliliters of fluid. So your lateral decubitus films can detect a smaller effusion and determine whether it's loculated on CT, and that can be more reliable. So your next best step in management is a thoracentesis. It's diagnostic and therapeutic if the etiology is unknown, as in this case with a history of cirrhosis, nephrotic syndrome, breast cancer, and CHF. So we want to determine whether it's transudative versus exudative with the Light's criteria, and the most common complication is a pneumothorax. So moving into Light's criteria, in order to be transudative, all three criteria must be met. The LDH must be less than 200, the LDH of the effusion over the serum must be less than 0.6, and the protein in the effusion over the serum must be less than 0.5. The most common cause of transudative effusion is CHF, and then cirrhosis, PE, nephrotic syndrome, peritoneal dialysis, hypoalbuminemia, and atelectasis are also common causes. You can treat this with loop diuretics and sodium if it's known. Exudative causes are bacterial pneumonia, TB, malignancy, metastatic disease, collagen vascular diseases. You can treat this with correcting the underlying disorder, and if it's complicated, like if there's a positive culture, if the pH is less than 7.2, or if the glucose is less than 60, a chest tube for continued drainage. Therapeutic thoracentesis and pleurodesis can be performed for recurrent or symptomatic effusions. So some of the effusion buzzwords to look for: if the pleural fluid has increased amylase, think esophageal rupture, pancreatitis, or malignancy. If it is milky in color as it's coming out, think of a chylothorax due to a ruptured thoracic duct or lymphoma. If it's a purulent fluid or the pH is less than 7.2, think empyema or lymphocytic predominance, look at TB especially. If it's a bloody effusion, think about malignancy. And if the glucose is less than 60, think about rheumatoid arthritis or also a empyema. So now a pneumothorax. So in this case, we've got a 28-year-old tall, lean male smoker who presents with sudden onset chest pain and shortness of breath after falling off his skateboard. So vital signs are BP of 124/82, pulse of 103, and respirations of 24. On exam, the left chest is hyperresonant with decreased breath sounds and tactile fremitus. Your next best step is going to be a chest x-ray, where you want to look for the visceral pleural lining with an absence of lung markings. So a primary pneumothorax is a rupture of a bleb in a young, otherwise healthy, and they commonly recur. You want to treat it with observations and oxygenation if it's less than 15% occlusive and asymptomatic, if there's aspiration, chest tube, or VATS for symptomatic patient, and large and recurrent patients. A secondary pneumothorax is a complication of lung disease, think COPD, asthma, or interstitial lung disease, and you want to treat this with a chest tube or a VATS. So now a tension pneumothorax is slightly different than a primary pneumothorax. So a 49-year-old presents following a motor vehicle accident with shortness of breath. Vital signs are hypotensive, tachycardic, and elevated respirations with unequal chest rise. On exam, neck veins are distended and the trachea is deviated to the left. And the right hemithorax is hyperresonant with decreased breath sounds and tactile fremitus. So the trachea deviating opposite the side of pneumothorax, the elevated JVD, the low BP, and the high pulse pressure is going to make you increasingly suspicious for a tension pneumothorax. And this is a clinical diagnosis, so the next best step is a needle decompression in the second or third intercostal space in the midclavicular line, followed by a chest tube placement. This is a medical emergency. It's no time to confirm on chest x-ray. You would see a unilateral absence of lung parenchyma and a contralateral mediastinal shift from this one-way valve that's forming, forcing air into the chest and pushing the mediastinum to the opposite side. So if this same patient had broken 2 femurs in the accident and 24 hours later there was a sudden mental status change, shortness of breath, petechial rash, and an AKI, you could think fat emboli syndrome. This is usually due to long bone fractures and polytrauma, and you want to treat with mechanical ventilation and prevent early internal fixation when possible. So now a pulmonary embolism. We have a 68-year-old woman with a hip fracture who was hospitalized 3 days ago due to delirium. Her condition improved and she was able to get up and move about without assistance, even though she had a bit of calf soreness. A few minutes after walking to the bathroom, she experienced sudden onset dyspnea with chest pain and diaphoresis. Your next best step here is to start a heparin drip and then to do a spiral CT. So treatment with heparin is before the diagnostic step of CT. So pulmonary angiography is the gold standard, but it's invasive. Chest x-ray rarely shows the signs like a Hampton's hump or a Westermark sign, and EKG rarely shows an S1Q3T3 sign. You can do a VQ scan, but that's rarely the answer unless they're unable to tolerate contrast or they're pregnant. A duplex ultrasound in the lower extremity can help if there's signs of DVT, but it's not a rule-out exam if they're experiencing PE-like symptoms. So you can look at your Wells criteria to determine whether they're low, intermediate, or high risk, and you can consider a D-dimer as a rule-out when they're at low risk. So you can treat them with supplemental oxygen anticoagulation with low molecular weight heparin or unfractionated heparin, dependent on their clinical suspicion. And then think thrombolysis if there's a massive PE with hemodynamic instability or right heart failure. And you want to continue coagulation with oral warfarin or DOACs for 3 to 6 months and lifetime if there's this second offense. So now pulmonary hypertension. A 47-year-old woman presents for fatigue and progressive shortness of breath with exertion. She's chalked it up to her symptoms being out of shape, but recently she noticed swollen ankles. Her vital signs were within normal limits. On exam, her chest was clear to auscultation, no rales or wheezes. On cardiac exam, a loud P2 is heard. There's a fluid wave appreciated in the neck when the right upper quadrant is palpated. So your next best step here is echocardiogram to look for mean pressure greater than 25. The right heart catheterization is the gold standard to look at the pressure within the pulmonary circuit. And then an EKG can show right heart strain and right axis deviation. So when you're classifying pulmonary hypertension, there are 5 major groups. So group 1 is pulmonary arterial hypertension due to idiopathic familial connective tissue disorders. Group 2, which is the most common cause, is left heart disease. So valvular diseases like mitral regurg or mitral stenosis. Group 3 is lung disease and chronic hypoxemia. So interstitial lung disease, COPD, or obstructive sleep apnea can all lead to it. Core pulmonale is right ventricular failure due to chronic hypoxemia. And then we can diagnose that on chest x-ray with a dilated right ventricle and right atrium. On EKG, you would see right axis deviation, right ventricular hypertrophy, and peaked P waves. or echocardiogram, you can see right ventricular hypertension. And then group 4, this is due to recurrent PEs, can form pulmonary hypertension. And group 5 is whatever doesn't fit into groups 1 through 4. So you want to treat the underlying disease. You can try trials of sildenafil, calcium channel blockers, or bosentan can be offered. Now we're going to move into the chest x-ray review. So the first case here is a normal chest x-ray. You can move through your A, B, C, Ds, E, F, G, H, Is. When you're looking at a chest x-ray, it's important to go through these steps systematically so that you don't miss anything. For instance, on the right side, there's a right upper lobe pneumonia. It's commonly called opacifications, consolidations, and air bronchograms. Now we can see a atypical or walking pneumonia, which is a patchy reticular opacities in the perihilar regions. And then on the right, there's a lung abscess. So we've got a cavity containing air fluid levels in the upper right. Now we've got tuberculosis, which is an upper lobe cavitation and hilar adenopathy. And then sarcoidosis, which is bilateral hilar adenopathy, and there's no cavitation, differentiating it from TB. Now COPD, you'll notice there's lung hyperinflation. You can see extra ribs there, and there's a flattening of the diaphragm. The heart is also a little bit more deflated looking and lower appearing. Next up, we've got bronchiectasis, which is increased bronchial vascular markings with a tram track opacification. Next up, we've got ARDS, or a diffuse opacities, or a whiteout. And we've got pneumothorax, which you can see the visceral and pleural edge without lung markings on the right. A pleural effusion, or blunting of the costophrenic angles on the left. And then lung cancer with a cavitating mass on the right. A pulmonary embolism, so you can see Fleschner sign, Hampton's hump, or Westermarck sign. And then interstitial lung disease with a ground glass opacities and honeycombing on CT. And then clubbing, we mentioned earlier, the next best step is the chest x-ray to look for the underlying lung pathology. It's usually caused by chronic hypoxemia, increased convexity of the distal phalanges due to soft tissue hyperextension or hypertrophy. And the differential is lung cancer, cystic fibrosis, interstitial lung disease, sarcoidosis, mesothelioma, bacterial endocarditis, inflammatory bowel disease, and primary biliary cirrhosis. So that marks the end of the pulmonary chapter. Next up, we've got nephrology and electrolyte disturbances.
I am Professor Patrick.
Professor?
Dr. Professor Patrick.